Good morning. It is February 10th. This is Senate Health and Welfare Committee, and we're continuing our meeting this morning separately from House Healthcare. We began at 9 o'clock with House Healthcare. So this is a continuation with Senate Health and Welfare. We're taking up S-285, a committee bill, and we have with us this morning a number of folks to testify on expanding the blueprint and access to home and community-based services. So we'll dive right into testimony, and Jill Olson is here. Thank you very much for being available. Why don't you start us off?
Great. Thank you so much. I'm Jill Olson. I'm the Executive Director of the VNAs of Vermont, representing Home Health and Hospice. It's nice to see all of you this morning. Including some of my fellow witnesses who I haven't seen in a while. I miss being in person. I have a few comments to make. I will send you a follow-up. I'm sorry, I just cannot get ahead of the deliverables right now. But I want to start off by just saying I'm going to be focusing on the moderate needs expansion proposal. That's going to be the focus of my testimony. And also wanted to say that I have been in close touch with Angela Smith-Jang from Dale, and have seen actually some language that I think she submitted to you this morning. So you may not have all taken a close look at that, but I have. And
yeah, no, thank you. She did. I should have mentioned that earlier to the committee. We do have it on our webpage.
Great.
It isn't a huge, long piece, so people might be able to glance at it.
Yes. So what I wanted to say, just to frame my comments, is that I did take a look at that. And while I haven't obviously shown it to my members, I think it's directionally something we could support. I anticipate wanting to maybe add a little bit of language about the administrative burden potentially on some of what she's describing in terms of analyzing those wait lists. I think she'd be amenable to that, so we can work on that. But before I launched in, I just wanted to tell you, I think we're on the same page with the administration. And so to the extent that's helpful, I wanted to say that. As I look at the report and think about moderate needs, there are a few things that I really want to share today. One is we share the view that the family caregivers are essential. The Choices for Care program and the needs of Vermonters who need care at home would not be met without family caregivers. And in fact, they're not being met even by family caregivers, home health agencies, adult day. The system is not actually able to take care of everybody who needs care. So those home caregivers, I believe they represent about half of those family caregivers, are about half of the at-home care that's provided in the highest needs program right now. So those are the people who meet the full criteria for long-term care Medicaid. So I think that that's really something to explore, and I know that that's something that the folks at Dale thought made sense to explore, and so I just wanted to express our support for that because we do think that's critical given our workforce shortages. Some of those family caregivers will really only take care of the person that's their loved one. They're not going to take care of someone else in the community necessarily, but they might take care of someone that is important to them. The second piece is I wanted to say that in terms of moderate needs, there's some language in the report about the need to prioritize and examine risk and need. So broadly, we agree with that. In fact, we've called for that for a long time. We've always had chronological wait lists for the moderate needs program. So just taking a step back, home health agencies have two roles in moderate needs. We serve as case managers, and we also provide the direct service of the homemaker service. So the wait lists have always just been chronological, and the eligibility criteria has been very broad. And so the concern that we've had for a very long time, and this is something that's now in process to fix, is that we could not take people off the wait list based on any kind of priority criteria around need. It was just literally who got on the wait list in what order. And so that's something we've wanted to work on, and also wanted to really make sure we're not putting people on that wait list. We want to make sure we're targeting that program to people who have a need and for whom we really are going to be hopefully preventing some care down the road. So there's already been some work done on that, and the Dale folks, I think, testified to you about some of that work, and we've been involved with it. I'm not sure a claims-based approach, though, is going to work in terms of identifying who needs what. And we've learned a lot about this program, because remember, at the beginning of the pandemic, when things were terrifying, I just want to remind us what it felt like in those early days. We were ordered under the governor's executive order to focus only on essential services, because nobody wanted us to go into a home that didn't need to have someone from the outside come in, and no one wanted us to go into a home where we might, where one of our staff might get COVID and bring it to the community. I mean, we were all very, very scared. And so most of home health services were essential. People who are coming out of the hospital post-surgery, most of the work we do, there's no way to not do it. And so it was really programs like Moderate Needs where agencies had to do a lot of thinking about who has an essential need for groceries, who doesn't have anyone else to bring them groceries. And so it's really a lot of what can change who might need the service has to do with, and how to prioritize their family supports, the structures in their community. So I have one agency that's actually has some grocery stores in their area that are starting to do home delivery. So they actually started using more flex dollars so that they could have the grocery stores do the delivery instead of hiring workers onto the home health agency staff to go do the grocery delivery, right? So just trying to be a little more creative about how to create some of these services and bring them to people. So I'm skeptical that a claims-based approach is going to get at people who have some of those needs. So I just wanted to, I think this is something that really needs further exploration, given what we know about this program. Let's see. Okay, now I'm going to get on my high horse just a little bit, so forgive me. I am very concerned about a proposal to invest more dollars in a broader caseload, given the pressures of the current program. You must know I'm going to say this. This cannot be.
Oh, we're ready for this. We are so ready for this.
Yeah. Okay.
We welcome your comments.
Yeah. We are already struggling as a long-term care system to provide care for the people who need help getting out of bed in the morning, who really have the highest level of need. We don't have enough people to do that work. And part of the reason we don't have enough people to do that work is because we have had depressed rates for this program for a very, very, very long time. We have never invested in this program the way that we needed to. Never. So we have scraped and fought and clawed our way to 2% and 3% increases over the past 5 years after a decade of no increases. We are still heading in the wrong direction. So we were at 1 in 4 caregivers vacant roles before the pandemic. We're now at 1 in 3 of those roles are vacant. We don't have the people we need because we cannot pay them enough. There's just no other way to say it. And our agencies have subsidized this program substantially. The losses are huge. And if actually, I can put in my comments if you'd like, I think my members will let me share this, what the losses are for each of them in your community, so you can see just how substantial it is. So they have really tried. They have really stretched. They are trying to make it work, and they are really struggling. So to see we might put millions more dollars into an expansion before we have taken care of the program that exists is something that we're going to have a really hard time getting behind. And just to remind you what we're talking about, the 3% increase for Choices for Care, home and community-based services that's in the budget now is $2.6 million. So we are not talking about giant numbers, and yet we struggle to get even a 2 or 3% increase every year into this program. So I couldn't. I actually promised my contract lobbyist that I was calm now, but perhaps not entirely.
You're doing very well. We hear you, and we look forward to the written testimony so we can figure out all of this. This is great.
Yep.
Jill, calm is overrated anyway.
Oh, oh, thank goodness, because it's not my style.
Yeah, I'm with you. Go ahead.
Okay, good. Thank you. So anyway, okay, I think I can climb down off of this now. The last thing I just wanted to say, and I think that this is really in the Dale proposal, is I really think you need more stakeholder input. So it's, to my knowledge, this report was developed without stakeholder input, and we really have experts. The case managers in the field and the direct service providers and are really experts at in this program. And home health agencies really understand our communities in ways that are, I really realized it, I think, about a year ago when we were trying to get homebound Vermonters vaccinated. Remember that?
Yes.
Home health agencies, AAAs, adult days, were able to make incredibly good lists of who in the community needed a vaccine because they were not going to be able to leave their house to get to a clinic. And so there's a closeness to the community and an understanding of the services that's there. And I really think it's critical that you not proceed without getting the input of those people who really understand what this work looks like and what the needs are and what they're trying to accomplish. So I just think that's got to be part of the process.
So as you're providing your written testimony and looking at Dale's paragraph or two, perhaps you could incorporate some of your thinking into that.
I will. I think sure, absolutely. Yep. I can. What I'll do is I'll structure my written comments around their proposal so that I can make any comments about how you might adjust it, and then the larger points that we're making, and I can certainly share that with you. I think that's actually everything I wanted to say. I don't know if you have any questions for me, but I think I can pause there. And
well, no, I think you've been pretty comprehensive. Senator Hooker will have a question.
Just a request, Jill, that you send that chart you were talking about, the loss chart, along with your testimony, please. Thank you.
Yeah,
be glad to.
Okay. And so I think what we've heard from you, I'm trying to inferentially understand that you might have a concern possibly about workforce.
You got it. Yes. That was excellent deduction.
Okay.
Yes. Yes.
Yeah. Thank you. We all do, and we're very empathetic, sympathetic, and concerned as you are, and it's trying to take two steps forward at the same time that we need to take two steps forward. So we're working on that, and that the whole area of workforce is something this committee will be taking up in earnest as we go through the budget process. Your concerns about reimbursement and payment for the services that are being provided is one I think at least I share, and I think others share. So we'll have to look at that. And we do have a bill in our committee, but it didn't have an appropriation. So we'll try and sort all of that out.
Yes. Thank you. I so appreciate you giving me the opportunity to comment and speak a little bit more broadly about the program too.
Yeah, no, it's great. Thank you. Other questions for Jill? And you'll get us your written testimony, because we're getting to the place where we're going to have to make decisions about what we're actually putting into the bill. We can't put everything in, but we certainly want to say something that will help us move forward.
Very good.
Okay.
Thank you.
Thank you. All right. Ina Backus is here, Director of Healthcare Reform, and Ina and Dr. Saroyan also here for the blueprint with others. And I'm going to ask you how you would like to structure your testimony. So go ahead.
Thank you. Yes. If we could, we'd like to provide the Blueprint program background as a starting point for our discussion. And I'll turn that over to Dr. Saroyan and the team to provide that. And then we would come back to talk about priorities for the program looking forward.
Terrific. I think that's great. I think members of the committee were very interested in hearing more about the blueprint to get a full understanding. So that's very helpful. And Dr. Saroyan, thank you for being here. I would share with you and Laura Reshnig. Is it Reshnig? Did I say that? How did I say that? How would you say that?
Reshnig, you got it. You got it. pretty
Okay,
good.
thank you. Your bios were submitted. They have been shared with the committee members. We don't feel a need to post those on the webpage. So just so you know that we've seen those. So Dr. Saroyan, there you go.
Good morning, Madam Chair. For the record, this is John Saroyan, Director for Blueprint Vermont. Madam Chair, 2 questions, just so I can organize our time as well as possible. May I still introduce my team members, Julie and Laura, as I had written first?
Yes, it's all up to you.
Okay,
we're giving you the
so-
time, and it's all yours.
Thank you. So I will, so that the committee knows, I will introduce Julie and Laura. They will present an overview of the blueprint, and we will pause there for questions before then Ina and I then move on to some of our future looking. So without further ado, I'd very much thank the committee for welcoming us back and for the honor of presenting 2 of our very valued team members. Julie Parker is a licensed clinical mental health counselor and one of our 2 assistant directors. She has been with the Blueprint for 2 years. Prior to the Blueprint, she worked in the designated mental health system in various capacities for over 20 years. Julie is passionate about the Blueprint's unique ability to support communities by integrating physical and mental health for whole person health and wellness. Laura Reshnig has an MA in economics and is one of our 2 data analytics and information administrators. She's worked for the Blueprint for nearly 3 years, managing payment operations for the Women's Health Initiative and the SPOKE program. She is also a member of the Agency of Human Services Institutional Review Board. She cares deeply about using data and analytics to inform decision-making in healthcare. I will turn it over to Julie and Laura. Thank you so much.
Good morning, everyone. Thank you so much for allowing us to be here. We're really excited to share about the Blueprint. As Dr. Sharon said, we're very passionate about our work. So I'd like to share some slides, and I know Erin, I did respond and say, may I share some slides? So it looks like I do have permission to do that. So just give me 1 second to do that.
We also have this on our webpage.
Okay, wonderful. Thank you.
Great.
So everyone can see what I have up at this moment.
Yep.
Okay, fantastic. I can't see everyone, so if someone has raised their hand, please feel free to interrupt me and let me know that, and I'm happy to answer questions as we go, and all of us at the end as well. So presenting a Blueprint for Health 101. I do have some slides at the end of the presentation around sort of a broader history of the Blueprint, but I think just for time's sake, and I think this is really one of our key pieces here, which is our 2010 Vermont Statutory Framework, Act 128, the mission of Blueprint for Health. And I just like to read it. Integrating a system of healthcare for patients, improving the health of the overall population, and improving control over healthcare costs by promoting health maintenance, prevention, and care coordination and management, which is really the building blocks of our program. I think one of the things you'll hear as we talk in our presentation is really about innovation. And I think that's something that the Blueprint is really proud of through the years. We really work with our community partners, our program managers, to hear from them what's going on in the community and what's happening in Vermont's system of care, and how do we rapidly bring those things together. Think inside the box, think outside the box, look at programs that might be happening at the Agency of Human Services and really bringing those things together, looking at design, looking how we implement, and also having a system of research so we can see what else is going on in the US that might be beneficial to us, and what are we doing that might be beneficial to others, such, you'll hear about our hub and spoke programming, which has gotten a lot of kudos, from other folks around that programming. So we really like to be innovative. We really love to work with our communities. And so we just feel like that's a really key component of our Blueprint, which hopefully you'll see that thread throughout our discussion today. So the foundation of the blueprint is really based on our patient-centered medical home model. And I will talk about that further. So that's the acronym is PCMH. If you hear that, that's what we're talking about. I'll try to use the full terminology here. So again, we're looking to improve the health of our population. And through that, we want to increase screenings, social determinants of health. So a lot of folks say, you know, SDOH. So that includes screenings on food insecurity, housing insecurity, interpersonal violence, depression, and there's a few other screenings, but hopefully that gives you a sense of what those screenings are. We want to help to support patients manage chronic health issues and get ahead of chronic health issues if possible. So hypertension, diabetes, asthma would be examples. We also want to enhance the patient experience of care. So we want folks to feel comfortable going to their primary care to talk about their reproductive health, their physical health, their mental health, their wellness, and really ensure we're ticking all those boxes and making sure we're getting folks to the support they need. But in order to do that, folks need to really feel comfortable and have a good experience when they go to primary care or specialists or whomever they're seeing to really be able to talk about what's going on for them. And in the end, we're hoping that reduces the cost of care. Providing good care, talking about what's happening, being preventative will hopefully, in the end, reduce the cost of care. One of the ways we get feedback, you know, we get feedback all the time from our communities, but we also have a Blueprint Executive Committee. And we present a lot of things to this committee who are, you know, within our state agency and in the field, and they can give us feedback to say, this is what we're hearing for our community. Or if we're making changes in our blueprint manual, they vote on those things and give us feedback. So again, an example of those are folks from AHS, Commissioner of Mental Health, private health insurers, home health, self-insured employers, peers. So we have a variety of folks, and in our statute, we meet every other month to talk and hear from that committee specifically around things we're implementing or discussing in the blueprint. So we really value that feedback and support and integration discussion. So we have a statewide network of hospital or health service areas, and a lot of folks use that interchangeably. So we'll say we have, you know, we have this many HSAs that we're working in. So when the blueprint began, the key stakeholders came together and they said, who will be the administrative entity for these funds? So a hospital, in most of our health service areas, the hospital is the administrative entity. And while those folks are a hospital employee, the grant that we have really indicates that they are looking out for the whole community completely. So they're working with our independent practices. They're working with federally qualified health centers. So even though they are, you know, hired by Northwestern Medical Center, they're still reaching out and do have that responsibility for the community as a whole. So the administrative entity receives multi-insurer payments to support the hiring of our community health teams. They must be centers for Medicare and Medicaid. And we have 13 program managers, and some of our communities hire a specific supervisor for the community health team. And those are called the community health team leads, but not everyone has that specific community health team lead. The program manager might fully oversee the community health team. And then we have our quality improvement facilitators, which again, I'll go further into detail. So again, each area gets a grant yearly to hire that program manager. It provides a salary. It also provides funding in some cases for the quality improvement facilitator. Some other quality improvement facilitators have different types of contracts, but program manager, again, they have the responsibility for the community, for the data entry, for the hiring, for the deploying of staff, ensuring that they're meeting the needs of primary care with the funding that they're receiving. And they also need to take a lead in what's called a community collaborative. And I'll touch on that. So our current programs, we have our patient-centered medical homes, community health teams, our hub and spoke system of opioid use disorder treatment, and our women's health initiative, pregnancy intention initiative. I'll be going into each of those. I'll start with our patient-centered medical home. So to be a part of the blueprint, you need to be what's considered a patient-centered medical home and meet the National Committee on Quality Assurance. So that starts off with you have to pay to join and you have to meet some national standards. So for example, a few examples, they need to ensure that they're documenting flu vaccines. They need to make sure that colorectal screenings are being done. They need to ensure that depression screenings are being done. So there are specific things that you have to maintain in NCQA. And then there are other sort of heading areas where you can make some decisions around what you'd like to do to meet a certain requirement of NCQA. So they have a care coordination that's kind of open, and they, you can do X, Y, and Z to meet this requirement. So the real benefit is there are specific things, and then there is some flexibility for what our patient-centered medical homes would like to improve on, and that can be different for each one depending on who they see or what area they are in or things like that. So, and the other requirement of NCQA is really ensuring there's continuous quality improvement. So you have to reattest every year, but in that reattestment, you're also looking to say, did we hit the marks we wanted to hit this year? We wanted to reach out to folks newly diagnosed with diabetes. Gosh, we didn't do that, or we did do that, but we're going to continue to look at how we can improve that quality. So those are some key elements to become a patient-centered medical home and meet those NCQA standards. So we have about 8 quality improvement facilitators, and some share our hospital service areas depending on how large the hospital service areas are. And so again, their role specifically within the blueprint is to help our practices maintain the NCQA standards, to help with any healthcare reform initiatives that we're working on and we're asking them to support us on. They did some quick shifting when COVID came about and supported practices with some things like that. Again, standard quality improvement, and they're always helping us look at the greater mission, which is the clinical cost patient experience work that we're identifying as our foundation. So I will turn the next few slides over to Laura Reshnig, who will speak to a little bit of data, and then it'll come back to me. Laura?
Thank you, Julie. So this figure shows the growth in the Blueprint PCMH program over time. And one of the key things to notice is that in recent years, growth has really leveled off. And that's partly just because of how successful the program has been in reaching most of the primary care practices in the state of Vermont. So as of 2021, Q3, we have around 300,000 patients that we attribute to patient-centered medical homes. Approximately 100,000 of them, so about a third, are attributed to Medicaid. And we have 135 patient-centered medical homes at this time. And throughout those 135 practices, we have 147 CHT staff FTE hired. Next slide, Julie. So once a PCMH becomes recognized as such, they're eligible for a few types of payments. So the first type of payment is the base payment, and the amount for this differs whether the insurer is commercial, Medicaid, or Medicare. Once they receive that base payment, they're also eligible for 2 types of performance payments, and these are an additional 25 cents that they could receive from commercial and Medicaid. So the first type of performance payment really looks at the practice's resource use index score. And this score captures not only the number of services, but each service's relative weight based on how resource intensive it is without the influence of price variation. The second type of performance payment is a quality measure, and it looks at outcomes at the community or HSA level. And some of these measures include the percent of adolescents with an annual well-care visit, or the percent of individuals with hypertension in control. And we look at these at the HSA or community level. And once again, both performance payments are up to 25 cents per member per month. Next slide, Julie.
Before you go, Laura, a quick question. How are the base payments determined?
So, and I would refer, I may have to provide additional notes on this, but typically the Blueprint PCMH programs, they're based on what a salary for a CHT staff would be, and that's how the CHT payments are calculated out, but I would have to get back to you on how the specific PMPMs are calculated.
Thank you. Yeah, that'd be great.
So this slide breaks out that commercial population of PCMH attributed patients, and what you see is, once again, Medicaid patients account for approximately 1/3 of the total patient-centered medical home attributed patients. After Medicaid, Blue Cross Blue Shield Vermont and Medicare also have substantial patient attributions, and then we have smaller patient attributions for the remaining commercial insurers, MVP and Cigna. Next slide, Julie.
Great, thank you. So I just want to speak just a minute about our community health team. So the goal of the community health team is supporting primary care, identifying root causes of illness, including the screenings we talked about, the social determinants of health, and really ensuring that we're connecting folks with the most effective interventions to manage and support chronic conditions, and just overall well-being for whole health. So there's a whole spectrum of support that they can offer. So we have our funded community health team, which we give some some leeway to our communities to say, what do you feel you need the most? And so typically it's nurses, mental health clinicians, case managers, care coordinators, those people use those terms interchangeably, panel managers, dietitians, community health workers. Those tend to be the main credentialing, so to speak, for our funded community health team. And then we want to just, ensure that we also identify the community as a whole health team, right? So we know we work closely with our designated agencies, our VCCI, Vermont Chronic Care Initiative, SASH, BEATA, Visiting Nurse, Home Health, Peers, Food Shelf, Housing. There's so many more. So although we have this funded group, we know that it's the community as a whole that is making a difference in supporting our Vermonters. So I just wanted to make note of that. So our Cht payment structure is health service areas receive funds from the insurers. So $277 per patient per month, commercial, Medicaid, $2.51, for Medicare. And that's for the staffing. So that goes right to the administrative entity. And there are different models for staffing in communities. Again, we've given some flexibility. So for example, in St. Albans, Northwestern Medical Center actually hires their mental health clinicians through the designated agency of NCSS that deploys out to the primary care, but they hire nurses. So there are other communities that all staffing is hired through the administrative entity, and then parsed to the primary care or, across the community. So we do connect with each area and talk about what would work best and why they feel that would work best. And then we're going to talk about some different payments. So we have our Cht structure of payment, and we'll talk about our spoke payments and our women's health payment. But that is the payment structure for the community health team. Okay. We also have our accountable communities for health, and that's what I talked about a little bit earlier. And some communities have named their groups, and so other folks just say this is our ACH, but it's a chance for the Blueprint program manager to really reach out to the community partners and come together in a way to talk about, again, what's happening in their community. So they could be looking at hospital data or data from the DA or from AAA in their area, and talk about what they really want their goals to be as a community. And some communities have broken up into smaller groups from this to work on, let's say, suicide prevention or opioid use disorder or different things like that. So again, there's some flexibility in terms of their unique groups that come together and how they break up the tasks that they want to work on. They look at their community health needs survey that hospitals do. So they take a lot of information and work together. And that is one of those groups that we ask the program manager to take a lead on bringing folks together. Okay, we're going to talk about Hub and Spoke and Women's Health Initiative, our pregnancy intention program. Hub and Spoke medication-assisted treatment started in 2013, and we know that research shows it's a very effective treatment for most people. Our federal regulations designate two settings that this can take place: medication-assisted treatment, opioid treatment programs, which are called OTPs, or office-based opioid treatments, which a lot of folks just call it the OBOT. So I'll try to not use acronyms, but those are the way folks talk about those. So we have our hubs that ADAP oversees, and we have 8 program sites. They just dispense buprenorphine and Vivitrol in addition to methadone. They have care managers, counselors, nurses, psychiatry, and they receive a bundled rate for that methadone and their home health services they provide. Then we have our spokes, and so the Blueprint are the folks that administer that programming and funding. And that's the office-based opioid treatment programming. We have roughly 75 practice sites, and Laura will speak to that more. We have some maps coming up. They prescribe buprenorphine and Vivitrol. And so for each 100 patients, they receive a full-time nurse and licensed addiction or mental health counseling. So the community gets the funding again through the administrative entity, and we may have a practice that has 30 patients or 100 patients or so. They will, combine those numbers and decide the point FTE that needs to go to each site to meet those numbers. One thing that's really important about this programming is the consultation between the hubs and the spokes. It's really important that we're getting our folks to the level of care that they need, and they can, that can vary. Somebody can be at a hub and receive more intensive treatment, move to a spoke. There can be some things that happen. They need to move back to the hub. So it's so important that our hubs and spokes are connecting, and there's that moving for levels of care. And then a program that the community's worked on is, embedding recovery coaches in our emergency departments, and also ensuring that if someone comes into the ED and says, I'm ready to make a change, I really need a different level of help here. If a prescriber is on site at that emergency department, they could start medication-assisted treatment. And the goal is within 3 days, they're working with their community partners to get somebody right in. They have pathways for referral and just really clear workings with each other in the community. If they aren't able to prescribe, if there's a provider there that just isn't able to do that type of prescribing, then the same thing, within 3 days, ensuring with the help of that recovery coach that we're encouraging and helping that person get to treatment as quickly as possible. I think we all know making a change is really hard. And so sometimes, when we have the motivation to do it, we really want to ensure that we can get to that and help somebody really get to where they need to be as quickly as possible. And that's really the work of the communities, making and building those pathways and referral pathways together. Laura.
So this is a map of the hubs, the centers that are administered by the Department of Health. You can see that across the state, we have good coverage across different communities. And these hubs, they remain relatively fixed. We have occasional closures or transfers, but these stay pretty consistent across the years. Next slide.
Okay. Oh. Go ahead. Sorry about that.
No worries. So this figure shows the growth in the spoke program since its inception in January 2013. And I just want to make a few notes. So when I say spoke Medicaid patients, what I'm really referring to is a 3-month average number of unique patients for whom Medicaid paid a buprenorphine or Vivitrol pharmacy claim. And so this is a rolling average, and this is how we try to measure how many patients are engaging with the spoke program. The spoke MAT prescribers in Vermont are the prescribing physicians on those claims. And so these are Medicaid patients and Medicaid prescribers. We also look at the spoke MAT prescribers in Vermont who have more than 10 patients, because we feel that those represent a different level of access necessarily than individuals who maybe have a panel of only 1 or 2 patients. And then we also have on this figure our spoke MAT FTE hired, and these are the CHT staff that work in spoke settings. And we receive these numbers through our Blueprint portal, which we'll talk about a little later, and these are submitted to us by our field. So you can see we've had a steady growth in the number of prescribers, the number of patients who are able to receive care, and the number of FTE staff in place throughout this period. So as of 2021 Q3, we have around 300 spoke MAT prescribers in Vermont serving around 4,000 patients. And we have about 83 prescribers who are serving more than 10 patients and about 75 FTE staff in place. Next slide.
We just wanted to note here, we've had some questions about the folks that work in those sites. And so the payment's a little bit different, but they receive $85,000 to hire a spoke nurse and $55,000 for the spoke counselor. And we just showed you a sense of what we ask of those of staffing in terms of credentials, and also the scope of work that we request that they're doing in terms of ensuring that we have a set of measures. They're called HEDIS, Health Effectiveness Data Set, that, ensuring that the weight's taking, the health screenings are being done, care transition, depression screenings, things like that. So we really spell this out for our Hub and Spoke network a little bit more in detail of the expectations of that role. Okay, I'm going to transition to Women's Health Initiative, our pregnancy initiative. So what we know from Department of Health is that through their PRAMS data, which is Pregnancy Risk Assessment Monitoring System, from their 2018 information, that's the most recent we have, that 45% of all pregnancies for Vermont residents are reported to be unintended. And the goal really for Vermont is to reduce to 35%. So when this came to fruition in 2017, the discussions that came together through different parties really talked about how do we improve access to family planning counseling. And so we started off with patient-centered medical homes, and then we moved into specialty practices. But the first leg is to really ask about pregnancy intention. Do you intend to get pregnant this year? And if the answer is yes, then we're ensuring we're doing screenings and that they have the best optimal chance to have a healthy pregnancy. So if the screenings indicate they're using substances or they're homeless, we want to get those things supported the best we can so that, you know, someone can have a healthy pregnancy and feel safe and secure. If someone says, no, I'm not interested in becoming pregnant this year, then we are able to provide family planning counseling. We're able to talk about the different most moderate effective contraceptions. And one of the most moderate effective contraception is a long-acting reversible contraception, such as an IUD, internal uterine device. And so we talk about those with patients. And then again, we navigate and send to treatment, send to support, send to wherever patient needs to get additional level of support if they need that level of support. Another unique feature of the Women's Health Initiative, similar to Spoke, is that we want to increase our community relationships with people because we know we may see someone in a specialty clinic that doesn't have primary care, and we want to make sure they have primary care. Or we see someone in primary care that needs to have specialty OB/GYN care, and we need to make that referral. Or we know right away if someone is 6 months pregnant and homeless, we would really love to work with the community the best we can to find resources for that person, again, to be, you know, in a safe place. So that's what's unique about the Women's Health Initiative. And
Julie, quick question about that. So I understand that the Planned Parenthood clinic in the Northeast Kingdom has recently closed. And was that part of the Blueprint Women's Health Initiative? And if so, how are you compensating?
yes, that's a great question. And it's been on a lot of folks' mind. And so, yes, Planned Parenthood is a part of our network, and they receive Women's Health Initiative funding and staffing. And, you know, there's a lot of variables, and ones maybe they haven't completely shared with us, but essentially, you know, their numbers are low. They're having really difficult staffing issues and maintaining providers for some reasons. So one of the things that we're doing is, I know that Planned Parenthood is connecting with North Country Hospital. They are a Women's Health Initiative site. So we're looking at how they can connect, move patients as needed. And I think Planned Parenthood also wants folks to know that some of those patients can still be seen for telehealth for lots of, you know, different types of visits. And yes, they need to come in maybe once a year or what have you, but that they still can do some in-between care if they have access, obviously, to a smartphone or other kind of technology. You know, I think the biggest concern, and so this isn't obviously all completely resolved, I think the biggest concern is younger folks that are saying that, you know, I really need to get on birth control, and I don't want to tell my parents, and I don't have a license, and I can't drive 45 minutes to the Planned Parenthood clinic. So I think those are things we're trying to figure out. You know, that youth population, I think this is going to be really challenging, and I don't know the answer at this moment, but I do know that we are talking about it. North Country's talking about it and really trying to identify ways we can get around it. It's difficult to hear that location closed. Yeah.
Thank you. Yeah, no, that's great. Thanks.
Yeah, absolutely. Yeah. So yeah, we, let's see. Laura, did you want to take this one? Right?
Yeah.
Yeah.
So this slide describes our payment model for the PCMH and specialty practices that belong to our Women's Health Initiative. So at this time, we have 45 practices, and so that includes 24 specialty practices, which includes 12 Planned Parenthood of Northern New England sites and soon to be 11, as we just discussed, and 22 additional PCMH sites. So slight typo there. So we have 3 forms of Medicaid payment based on the attribution of people who can become pregnant ages 15 to 44. So there's the recurring per member per month payment. And just as with the PCMHs, this is a monthly payment paid out by the participating insurers, which for this program is just Medicaid at this point in time. And it's $1.25. And I can follow up more information on how that $1.25 was arrived at. I don't have that information right now. So both types of practices, specialty and PCMH practices, receive this payment. And then specialty practices receive additional funds to hire a mental health clinician. And every practice receives a minimum 0.5 FTE. For every additional patient, the administrative entity receives $5.42 above that 0.5 staffing to allow for increased staffing. So when this model was first designed, it was determined that WHI PCMH practices, they already have existing CHT staff to support WHI goals. And so WHI PCMH, patient-centered medical home practices, do not receive this community health team funding. This funding is specifically for the specialty clinics. So in addition to the recurring per member per month payment and the CHT staffing, practices receive, when they join the WHI, a one-time per member payment that is designed to support the stocking of most and moderate effective contraception, such as long-acting reversible contraceptive devices. And this really is designed because these devices are often very expensive. And so this one-time per member payment is hopefully going to allow practices to stock up on these devices. So if patients want to choose one of these methods, they have them on hand. And we have more information available in our Women's Health Initiative Implementation Guide on how we attribute patients and how these payments function. Next slide. So this slide shows our growth in the program. And so as we discussed on the previous slide, we have 24 WHI specialist practices at this time, and we have 22 patient-centered medical homes that participate in the program. Across these 46 sites, we have 15.9 FTEs. And at this point in time, we have about 13,000 patients that we attribute to the program. And just a reminder that these are Medicaid patients. And so we do this using a 2-year look back. So we have had steady growth in the number of practices that are engaging. Next slide. So we have on our website a variety of different evaluations and types of profiles that we have done over the years. One of these is the community profiles, and these look at how different HSAs compare on different quality measures and utilization measures. We also have some practice level analyses, and we also did evaluations of the WHI and the hub and spoke through profiles that focus specifically on those programs and quality measures related to that population in each. We also, for the hub and spoke, have received a lot of attention nationally on how the program has functioned. And so we additionally have some peer-reviewed articles and some evaluations that have been done on the hub and spoke network. We also produce every year an annual report that describes initiatives that our field teams have launched and updates everyone on the growth of our program and important developments. So these are all available on our website. Next slide. So in order to administer and evaluate our programs, we utilize a variety of different data sources. So one of the most important is our Blueprint web portal. And this allows for our field team staff to communicate to us important information about what providers are at what practices are engaging in the program, what their NCQA recognition statuses are and dates. And so this allows us to keep track of sort of the administrative aspect of the program. We also utilize de-identified claims data from the Vermont Healthcare Uniform Reporting and Evaluation All-Payer Claims Database. And this data is used partly by our analytic contractor to help us determine aggregate Blueprint patient attribution counts. And we also receive information from insurers on patient attribution counts and payment totals. We use the identified Medicaid claims data from the Vermont Medicaid Management Information System to do things such as the WHI attribution process. And we also receive Medicaid Accountable Care Organization capitated payment data from the Department of Vermont Health Access. We receive feeds from the Vermont Department of Health Vital Records Death Registry. And we also receive clinical data extracts from electronic health records via the Vermont Information Technology Leaders. Finally, each year we participate in a patient satisfaction survey, the consumer assessment of healthcare providers and systems. And the results of this survey are posted on our website. Next slide.
We've also shared with you, links to the resources on our websites. I've included 2 slides around the history of the blueprint from 2003 to current 2021, and you can look through those if you have further questions. I know I focused on the one in particular. And then just any questions or thoughts. We love to talk about our programming. I'm happy to move back to any slides if there were questions or things you want to look at for a few more minutes, but we'd love to just open the floor to any questions you might have of Laura and I, or Dr. Swerin or Ina.
Okay, why don't we take the slides down? We can always go back.
Absolutely, can do.
And I think, there is additional testimony, I think, listed, but we'll get to that.
Yep.
So, yes, I saw that. Committee questions for Julie or Laura. Senator Hardy.
Thank you. Just one comment. First, your slides on your increase in staffing and patients. At first, that was very confusing because it looked like you had more staff than patients until I realized you were using 2 different x-axes. But I was also really struck by the difference in salary levels between your nurses and your mental health practitioners. And I don't know if you have anything more to say on that, but I was just really struck. I mean, both of them are too low, but the fact that there's a $30,000 difference between someone who, both of whom would probably have master's level education was striking. But my question, and maybe Laura and her additional information would get this to us about how the payments are determined, because I'm assuming that or all of your practices that you work with are primary care practices, or most of them are. And one of the things we're trying to figure out is how to better support primary care practices. And is it possible to just increase the individual per patient payments to provide better support to these practices as one avenue, or to expand the number of things that you're making the payments for? I think there was some mention in our previous testimony about work you're maybe doing on diabetes, and I didn't see any payments specific to diabetes. So those are my 2 questions: either increase the individual payments or expand the number of things. Which is your preference?
Yes, Senator, and I can provide additional information on how we arrived at those per month payments, and that may shed light on how easy or difficult they are to increase. Thank you.
The other question, I think, does that go to Julie or Ina or Dr. Soroyan?
Yeah, whoever can answer it, the increase the individual payments or expand what you're paying for.
Or both.
or both? What is the best route here?
As we discuss the future priorities for the program and our forward-looking focus, we will get into conversation about payer participation at parity across programming. This is a multi-payer program at its core, but as it has evolved and as we have continued to innovate, you did hear from the team where Medicaid is the key participant in programming, and commercial payers are not participating in the same way as Medicaid is, and that is the area that we want to explore for to better provide the services that are proven through these programs already.
So you have further testimony that we'll get to this. So let's ask Senator Hooker for her question, and then we want to get to the rest of your testimony.
With regard to people who are involved, I mean, how do they get involved? Does everyone who goes to any of your providers, if they're on Medicaid, automatically, are they automatically counted as participants in these programs? And you talked, Dina, about commercial subscribers not having as big an uptake. So how do they get involved?
I'm going to let the team answer that in terms of, number one, there are practices that are participating in the Blueprint for Health program, and they cited that number, about 135 practices that participate. And then those practices as participants have a number of patients that are attributed to them, and that is how individual payments are made to those practices. However, this really is a model that is a utility model. The practices that are participating in the Blueprint for Health, they are certainly providing consistent services and supports to any member of their practice. And I'm going to ask the team to elaborate.
Senator, just to answer your question about how patients are attributed, we used a claims-based attribution method. And so, for example, a patient is attributed to, for example, a WHI practice by receiving some set of services that we consider part of the WHI, for example, breast cancer screening, contraceptive counseling at a given practice. And we use our data from the Blueprint portal on which providers are at a practice in order to kind of assign patients to a given location.
And that's attributed, excuse me, I'm sorry to interrupt.
No, finish the question, the answer to the question. That's good.
I think it's very important to characterize the attribution for the Blueprint program, the Patient-Centered Medical Home program, as being for the purposes of payments to the practices, but for the purposes of how care is delivered, any member of that practice, again, is receiving supports that are provided by the community health teams, is benefiting from that project manager that's working with the practices in the community. It's a resource that's available for all. So it's not that a patient would be excluded from this model of care because they are not attributed. They're being attributed in order for the payments to flow to the practices.
So if we have, for example, at a women's health initiative practice like Central Vermont Women's Health Center, we're really payer agnostic, so if we have somebody that comes in with Cigna and is having a challenging time and needs to meet with that women's health initiative social worker, mental health clinician, absolutely going to get a warm handoff and be able to help and support that patient. So absolutely, we're going to support everyone, although we know that the payments are only coming from this, Medicaid at this time from Women's Health Initiative.
I would just also like to add that we do not have insight into how the commercial payers attribute patients. We can speak only to how Medicaid attributes patients in terms of the payment structure.
Senator Cummings, thank you. That was a very complete answer, and I think it helps a great deal. Thank you. Senator Cummings.
Yeah, just are these independent practices or are there hospital affiliated practices that are also members? Because I think hospital affiliated clinics around here do a lot of the primary care. Seems to be where our primary care docs are.
It would be a combination of both. So if someone is a patient-centered medical home, they can receive community health team dollars and patient-centered medical home dollars. So, you know, if we look at Central Vermont Medical Center, they have their practices that are hospital owned, and then we have an FQHC, and then we have some independent practices. So they have the ability to say, you know, gosh, this is how many patients we have, or this is how many dollars we can get. And so Central Vermont Medical Center might funnel those dollars to that independent practice, and they're able to hire a mental health clinician or a nurse or a dietitian, or again, whatever they really feel that they need in their practice. So the dollars that are going to administrative entities are for the hospital and practices, independent practices, FQHCs, if they're patient-centered medical homes in the community.
More than 75% of primary care in the state of Vermont are participating in the Blueprint for Health program. Hospitals, independent, FQHC alike.
Thank you.
Okay, yeah, good. I have a bunch of questions I'm going to save, but so because I'd like to hear the rest of your testimony. Unless the committee has other questions, why don't we move ahead?
Okay, I will share some screens for additional slides. Dr. Soroyan and Ina will present those.
Thank you, Julie. Thank you, Madam Chair. And thank you, Laura and Julie, for that fantastic presentation. Super.
We're going to take it everywhere. This is really great.
And
Thank
I
you.
can present it everywhere, and I do oftentimes for new staff and community partners. So if there's someone you want me to present this to, I am absolutely more than happy to support in any way in doing that. So
Thank you.
absolutely,
Thank you.
absolutely. Okay.
Thank you,
And
Julie.
just let me know when you, want me to move slides forward.
Thank you so much. As Vermont treads the path to recovery from the COVID-19 global health pandemic, access to healthcare and human services is a top priority of the Agency of Human Services and the Blueprint for Health. Next slide, Julie. Expansion of Blueprint for Health must be driven by the principle of increasing access to health and human services for Vermonters. Preventive and necessary services have been deferred by Vermonters due to pandemic isolation, workforce availability, and new demands on the system. Furthermore, the need for mental health and substance use disorder has grown significantly from pre-pandemic levels. Program expansion and evolution should support primary care, mental health, and substance use disorder. Next slide. We propose to conduct a systems assessment on primary care access. Questions might include, and this is very similar to some of the work that Ina has led in regards to wait times for specialty appointments. Specific to primary care, these questions might include the impact of the pandemic on primary care, access of a new patient versus an established one. Is primary care being delivered in the ED and urgent care? Is it being delivered in the primary care mental home? What is the setting of it? There are many other more specific questions that could be asked. Same day availability, after hours, weekend coverage update. But this is the first part of our proposed work. Julie, next slide, please. And then as Julie spoke so eloquently about the quality improvement facilitators, expanding their work with the primary care medical homes beyond the National Committee on Quality Assurance Standards, beyond what perhaps they've decided, as you've just heard, within their own HSAs, what their community's needs are. We would propose to expand QI network activities to learning what primary care access assessment teaches us. So bringing people together to learn how to take that assessment and actually operationalize it to improve things. What are the needs? Where do things need to be shored up? Also collaborating on best practices for specialty care referral. That would segue from work around the specialty wait times work as well. And then lastly, and I think this is what of some of the conversation I was trying to articulate last week, and I'm wanting to do now too, is not only to evaluate state performance on existing patient-centered medical homes, but also to compare some of those things to NCQA, that National Committee for Quality Assurance Standards, more nationally. So that, yes, of course, we want to look at our differences year over year within our own health service areas, but can we leverage the National Committee on Quality Assurances to look at how we compare and then create that as a motivator and a unifier to look more broadly at what quality improvement activities could go on. Next slide, please, Julie. Thank you. Around expansion to support mental health and substance use disorder treatment, expanding and standardizing the spoke model of care across all payer types with an initial focus on commercial payer participation in the spoke model of care. We'd also like to address spoke quality and performance as some of our providers are self-identifying and wanting to serve only in the spoke role, and looking at how we might standardize their quality and the holisticness of which they approach serving this vulnerable and having and larger population. This is a point of discussion for our executive committee, which I'm calling with Julie's help and our other assistant directors, Mara, in March. What other substances also would the hub providers recommend expansion for? Since the inception of the program, the focus is on opioid use disorder. And while one of the drugs can also be used in the prevention of recurrence of alcohol use disorder, might there be informed decisions with the executive committee, with the Department of Health and hub providers about really addressing or at least moving towards addressing polysubstance abuse. So the deaths, the injuries occurring even more severely when one substance is in addition to another, Next slide, please.
Can I ask a question right
yes,
there?
Of course, Senator Lyons, of course.
Just a quick question. So if you're moving to polysubstances, and we understand that it goes beyond the initial counseling episodes and there are continuing counseling, but are you thinking about recovery centers and more inclusion of some of our other community services as a way of expansion? Is that part of the discussion?
Julie, do you know more about those discussions than I do? Senator Lyons, I'm going to defer to Julie.
Yeah, no, that's fine.
Okay.
Yeah, absolutely. I think it will be, and it has to be, right? There's little pieces in the community, right? We have our designated agencies, we have our preferred providers, we have our recovery coaches. We have a few things that need to come together to make a full puzzle piece in this work. We can't do it alone. We have to be a part of the larger community. But absolutely, I think as we look to expand, I think we need to also gather information about what are our preferred providers doing, what is the DA doing, what can we do, and what's missing there. And that is the work I think we really need to do to understand that whole picture, working with Alcohol and Drug Abuse Agency and all those other community partners, so that we fully understand the picture and where we can fill in those gaps. That's I think our perspective.
Yes, well, I mean, it's been an ongoing concern for me in terms of having coordinated and continuous care. And so I think it's critically important. And then going back to one of Senator Hardy's comments around pay differential, obviously that becomes a huge decision to make about how to proceed. But anyway, so we'll be thinking about that in our committee, and I hope that we can think about that together with you.
Thank you, Julie, and thank you, Senator Lyons, for bringing that up. And yes, that's what we would like to be thinking about with you as well.
Terrific.
Longer term goals and role for Blueprint for Health. we want to contribute to integrated preventive care and for complex care coordination. Both are central and necessary activities around value-based reimbursement. We want to collaborate to explore new approaches to an all-payer model for value-based reimbursement. The Blueprint for Health program and infrastructure are critical considerations, including this potential additional expansion and evolution is the way I like to think of it, of our program, which, as you've seen from the presentation, has been present right from the beginning. And then a topic that's hugely important and wonderfully complex, as Laura, I think, helped to present, was a data governance model, data sources, data standards, data access, policies and procedures for the aggregation of these datas, including social determinants of health, including what the access of Blueprint staff centrally is versus in the health service areas. What are the responsibilities? And then what implications does that have about what our team can do, and what of its scope would either need to be shared or expanded from within? I think I'm just going to make some brief comments about two references that I included. The first is specific to rural America and is current and is where much of the thoughts that Ina and I and the team have shared with you all today is from that reading. And then in the second one, Blueprint actually is mentioned in this National Academies of Medicine's report on PDF pages, I believe 69 to 73. There's a page and a half about the Blueprint. So that was pretty cool to see. And it's also just an excellent document. I don't want to add to your reading list, so I was trying to just be focused with that. If we could have the last the slide, that's the references slide, I think, and then the last slide. And then I think you can probably take the slide deck down. Ina, thank you. Julie, thank you so much.
This has been terrific. Thank you so much. I think it's been very helpful to the committee generally, and there's a lot of specific information that we can refer to. In terms of you have goals listed, and then some of the needs for the expansion issues and the needs coming up. And there are things that I think our committee will be very interested in helping to move forward. Obviously, a lot of what's happened with the Blueprint has happened. We've had some legislation, the Blueprint's gone forward, and then we've come back and we've done some legislation to fine tune things. Even on the hub and spoke, I think that might have been the last iteration. So the question is, next steps that I think we should be taking in terms of expanding primary care and the prevention piece, but also then around mental health has been critically important in this committee. And how can we work to expand the mental health, and as you mentioned earlier, the polysubstance stuff. So we'll be looking for some support or some language and some things that we can do with you. We know we can't do it without you. And nor do we want to do it without you. So we'll be in communication, and I would hope that you could provide us with some concrete recommendations that we can act on legislatively.
Thank you, Senator Lyons. And Senator Hardy, I do want to just give a little more background to a question that you had brought up earlier. I believe members of my team, as well as members of the Department of Health, are presenting to the Green Mountain Care Board on Wednesday of the coming week about the, help me, Ina, the
diabetes prevention programs and the chronic disease self-management programs in the context of essential health benefits for Vermonters.
Thank you, Ina. Senator Hardy, I'm happy to hear your question. I just did want to get back to you about that presentation coming up, which we're working on, and I know was referenced in the committee you all were in just before this one.
Yeah, thank you, Dr. Soroyan. You're right. Kevin Mullen referenced it. And so I was curious about that. And is the intention with that program to try to get similar payments to practices that are participating in it, similar to what with the Women's Health Collaborative and Hub and Spoke?
Oh, I hear your question. I see. Ina, do you want to take that first? Yes, I hear your question, Senator Hardy. I was just processing.
The Blueprint for Health program does have designated funding that supports the delivery of chronic disease self-management programs in the state of Vermont. And that funding is currently provided via MOU to the Department of Health, and the Department of Health is managing the delivery of those programs. In the MOU between the Blueprint and the Department of Health, there are some very clear goals for amplifying those programs, certainly modernizing those programs and increasing access to them across the state. Today, a Vermonter, regardless of their insurance type, has full access to those programs and can enroll in the programs. We are going to be monitoring and working with our partners in the Department of Health over the next year, since this is a new model of collaboration that started in October, to determine how the Department of Health drives more activity in those programs, more uptake perhaps is generated in the programs. And then I think that might be an important time for us to revisit whether funding for those programs should be delivered in a more all-payer design rather than the way they're funded today, which is through the Blueprint for Health appropriation.
Okay, that's helpful. So hopefully as more people, let me just repeat what you said, hopefully to make sure I understand it, as more people participate in it, it could move to this model of a per patient payment, the 25 cents per patient, similar to what you have in your other programs. But at this point, not enough people are participating to make that payment system viable. I think it's,
no, that I wouldn't say that it's
okay.
Not enough participation.
That's what I heard. So
I think we want to understand what program participation looks like in light of the Department of Health's management of the program. I think the team is preparing to present about this programming to the Green Mountain Care Board, as Dr. Saroyan said. And Vermonters are participating in these programs today and have been throughout the Blueprint programming. They are not inaccessible. Can they be amplified, and can there be more participation? I think that's what we're very much focused on. But there's been ongoing participation in these programs with successful graduates of the programming each year.
Okay, so thank you for that. So back to my question previously about payment to better support primary care practices that are participating in your programs. I heard you say you want to try to expand the number of payers who are participating, trying to get more private payers on board. And that's similar to what Josh has talked to us about, but I haven't heard specifically how you would do that. And then my question again about the number, whether increasing the individual payments, and I keep going to the 25 cents because it's easy, should we go from a quarter and just add another nickel onto that? And maybe that would be better, or just expand the number of things like the diabetes, like I just mentioned, into a per patient payment system. I'm trying to figure out how do we combine our goal of expanding or improving the Blueprint for Health with our goal of providing better support to primary care practices, and do it in tandem and in coordination.
So I want to emphasize part of the question that you asked, which I think is really critically important. And that is, how do we get the commercial payers with greater involvement? So, and then how do we, with that involvement, then expand the all-payer model so that we then have more consistent reimbursement for primary care that really provides sustainability. So that I thought that was an important part of that question. So is there an answer to that, I guess? How do you get the commercial payers? How do we increase that participation? And I know this has been something you've worked on for a long time.
As we've shared, the program is a multi-payer program with payer participation currently in the PCMH. The team put up a chart with Cigna participating in that, Blue Cross, MVP. So there is the precedent that this is a multi-payer program. When the program evolved to address opioid use disorder and to create the hub, the spoke component of the hub and spoke model, and then evolved further in the Medicaid space, that evolution was, first in testing how these programs worked, meeting a critical need, certainly for Medicaid enrollees. And with that, with those programs now well underway and tested, I think it's important that we use that same blueprint all payer framework to work with commercial payers to bring them into the same payment model design alongside Medicaid for these components of the program that have evolved. We have a framework to do that. The blueprint framework does support the all payer participation. I think where we need to focus our efforts and where we've certainly prioritized for the coming year is in carbon copying that design that we've tested in the Medicaid space for the commercial space.
Okay, I guess what I'm not hearing that you need anything from us. We have this bill that doesn't really have anything in it at the moment, so we're trying to figure out what to put in it. We heard from the moderate needs group that they don't want us to expand because they don't have in a way that would put pressure on their staffing. And now I'm trying to get from you all what you would like us to do to quote unquote expand the blueprint. And I'm not hearing anything, and maybe I'm misunderstanding, so I apologize for that. Long day of testimony. So if you still need to think about it and come back to us, that's totally fair, but I don't want to do a bill if you're already doing and just say what you're already doing. If you're already doing what needs to be done and you don't need anything from us, that's totally fair and totally fine. Just say that. But if you do need something from us,
Senator,
tell us what it is.
Senator, I appreciate your comments. And that was the question I asked earlier was for these folks to put together some of the recommendations that should be made so that we can move blueprint and primary care forward. A lot of the work needs to be done in the legislature. Some of this is not going to happen without it. Some of it will. I mean, it's been very organic going along. And as I said before, we had legislation, then we had hiatus, then we've had legislation, and now we see a need to increase participation. And that hasn't happened. And so now I'm thinking maybe it's time for a little nudge along the way. So we'll be working on this. And as I shared with the committee, we'll continue to work with Ledge Council on this. At least I will for the time being. So any other comments or questions at this point? I want to thank you all. I think that we may reach out again. Of course we will, and we look for your further comments. I know that Dr. Saroyan, as you went through your second slide, the second slide deck, you did have some comments and suggestions, and we'd like to hear the suggestions to help move the program forward. We're not. We keep waiting for things to happen, and so we're impatient people. We'd like to see something happen, and we'll be talking with our consultant about what he has heard, and we'll keep working on this.
Thank you, Senator Lyons.
Yeah, no, thank you, Dr. Saroyan and Ina and Julie and Laura. Thank you. Greatly appreciate the time that you've taken to educate everyone about the blueprint.
Thank you for
So-
having us.
Good. I think, Aaron, we can go